Hello, my name is Teresa Scordino, and I'm a hematopathologist at the University of Oklahoma. In this module, we're going to do a brief tour of the hematology laboratory and learn about how the laboratory performs a complete blood count, which is a commonly used laboratory test. First, a quick review of what happens when we collect a peripheral blood specimen. If we collect a blood sample into a collection tube that does not contain any anticoagulant, the blood is going to clot pretty quickly. Now, this might not be a problem for some blood chemistry tests that require a serum sample. However, with the CBC, we are trying to analyze the cellular components of blood, so we need it to be in an anticoagulated liquid state. So, specimens that are collected for CBC testing are collected in tubes that contain an anticoagulant called EDTA, which prevents the specimen from clotting by binding calcium. If we take a sample of blood collected in EDTA and allow it to settle, the blood will separate into plasma, which is the liquid part of the blood that's going to contain the plasma proteins, immunoglobulins, electrolytes, and other compounds. Under this, we'll see the buffy coat, so this is going to be all the white blood cells and platelets. And then at the bottom, we have the red blood cells. So the percentage of blood volume that is comprised of red blood cells is also called the packed cell volume. This is going to be equivalent to the hematocrit of the specimen. This image shows a diagram of an automated hematology line similar to those seen in many hospital hematology laboratories. The sample seen at the right side of the screen is placed on an automated track system. The track system first takes the sample to one of the automated hematology analyzers. Note that in this case there are two identical hematology analyzers on the line. The number of hematology analyzers on the automated line will vary from laboratory to laboratory depending on the volume of CBC specimens that a laboratory receives in an average day. So while this hematology line shows two CBC analyzers, a larger lab may have 3 or more analyzers on the line, and a smaller lab may have only 1. The automated hematology analyzers perform the CBC and automated differential count. If the CBC and automated differential count are normal, the results will be automatically transmitted to the electronic medical record. However, if there are abnormalities in the blood cell count or differential, or if the instrument flags the results as unreliable, the results will not be transmitted to the electronic medical record, and the sample will be sent down the track system to the slide maker and stainer so that a slide can be made for manual review. In larger laboratories, there may also be an instrument on the automated line that scans the slides and takes digital images for review. So now that we know the basic process for performing a CBC and differential, let's go through each step in a little bit more detail. When the specimen arrives at the CBC analyzer, the analyzer picks up and mixes the tube, scans the barcode, then aspirates some of the blood from the tube for analysis. Most automated hematology analyzers use the impedance or Coulter principle to perform automated cell counts. Cells in the sample pass one at a time through an aperture between 2 electrodes. Because cells are poor conductors of electricity, there is an increase in resistance as each cell passes through the aperture. This change in resistance generates a voltage pulse that is proportional to the cell volume. So basically, the number of pulses will tell the number of cells, and the size of the pulse helps differentiate between the different types of cells. So white blood cells, red blood cells, and platelets are going to be classified on the basis of size. One potential pitfall is if there are clumps of cells present in the sample. This image shows a platelet clump. Because the platelets are stuck together, they're not going to be counted individually, and the hematology analyzer will not recognize these large clumps as platelets. Platelet clumping is a cause of a falsely low automated platelet count. In addition to cell count, the hematology analyzer also reports a number of red blood cell parameters that can be useful in the differential diagnosis of anemia. Some of these red blood cell parameters are directly measured by the analyzer, and others are calculated from the measured parameters. It is important to remember that any inaccuracy in the measured parameters will translate into inaccuracy in the calculated parameters. The measured red blood cell parameters include the red blood cell count, hemoglobin, which is measured after lysis of red blood cells, the MCV, which is the mean corpuscular or mean cell volume, and this is the mean volume of red cells derived from the red blood cell histogram. The red blood cell histogram is a graphic representation of the red blood cell size distribution and is usually represented as a fairly narrow bell-shaped curve. The RDW is the red cell distribution width. This is also derived from the red blood cell histogram and is an indicator of the degree of variation in red blood cell size. The calculated parameters include hematocrit, MCH or mean corpuscular hemoglobin, and MCHC or mean corpuscular hemoglobin concentration. I've provided the equations for each of the calculated parameters, and these will be important for any pathology residents who are reviewing this module, but this is beyond what would be considered necessary knowledge at the medical student level. So let's talk briefly about the significance of those red blood cell parameters. So red blood cell count, hemoglobin, and hematocrit are all going to be decreased in anemia. MCV, which again is the mean corpuscular or mean cell volume, is going to help narrow the differential diagnosis in patients who are anemic. So for example, depending on whether the MCV is normal, low, or high, that's going to subdivide anemias into normocytic, microcytic, or macrocytic. And each of those is going to have a slightly different differential diagnosis. RDW, or red cell distribution width, again, this is going to indicate a variation in red blood cell size. So one situation in which this is useful is in the case of a microcytic anemia. In iron deficiency anemia, we tend to see an increased RDW because we have a lot of cells that are sort of differing in size, whereas in thalassemia trait, the cells are pretty uniform in size, and so we would expect to see a low RDW. MCH, or the mean corpuscular hemoglobin, this is going to be decreased in iron deficiency. And then MCHC, the mean corpuscular hemoglobin concentration, this is not as clinically useful. We may see a mild increase in patients that have an increased number of spherocytes. However, this parameter is a little bit more useful for troubleshooting in the laboratory. When we see a really marked increase in MCHC, that suggests a specimen problem such as red blood cell agglutination that's going to be further investigated and addressed before the results can be released. In addition to performing a white blood cell count, the hematology analyzer is able to perform an automated differential count to determine what types of white blood cells are present. The analyzer is able to separate out populations of white blood cells based on their light scatter characteristics. Light scatter provides information about the size and structure of the white blood cells. The amount of forward scatter is proportional to cell size. A larger cell will have a higher amount of forward scatter. The amount of side scatter, or 90-degree angle scatter, is proportional to the internal complexity of the cell. So for example, a cell that has a lot of cytoplasmic granules has higher internal complexity and higher side scatter. Some hematology analyzers also incorporate fluorescent dyes to help classify white blood cells. Based on their light scatter and/or fluorescence characteristics, the white blood cells are subclassified into lymphocytes, monocytes, neutrophils, eosinophils, and basophils. The more advanced hematology analyzers are capable of performing a 5 or 6-part automated differential count, and this is going to include granulocytes, lymphocytes, monocytes, eosinophils, basophils, and with some analyzers, immature granulocytes. The advantage of an automated differential count is that the analyzer is capable of counting thousands of white blood cells for each sample. So this is going to be a more accurate differential count than a manual differential, as long as no abnormal cells are present. If there are abnormal cells present, the analyzer is not going to be able to definitively identify those cells, so it's going to flag and a slide will be made for manual review. Manual review includes a manual differential count, which is only a count of 100 cells. So because we're counting a lower number of cells, these counts are more prone to variability depending on which part of the slide is being counted. However, only the manual differential can detect and identify abnormal cells like blast and lymphoma cells that the analyzer is not able to identify. So laboratories develop criteria for when manual differential counts need to be performed, and these are going to be based on instrument flags. So if the analyzer is flagging that abnormal cells might be present, that would be an indication for a manual differential. And in addition to that, laboratories may set additional criteria. For example, white blood cell counts above or below a certain threshold or certain patient characteristics. When a manual differential count is indicated, it is a 100 cell count that is performed by a hematology laboratory technologist. The technologist will manually review the slides under the microscope, and in some laboratories, they may review digital images of the slide at their computer terminals. In addition to having criteria for performing manual differential counts, laboratories also have criteria for findings that need to be reviewed and confirmed by a pathologist. So an example of this would be the presence of immature or abnormal white blood cells like lymphoma cells or blasts, or red blood cell morphology features that are concerning for hemolysis. Once the CBC is complete, the sample tube is returned to the track system and then it moves down to the slide maker. If there are flags that necessitate a manual differential, a slide will be made from the sample and then the slide will be fed onto the slide scanner. The slide scanner then will take pictures of a number of white blood cells. So basically it scans around until it sees a cell and then it starts to photograph those cells so that a differential can be performed. After the cells are photographed, initial classification of the white blood cells is performed automatically with image analysis software. These images have to be reviewed by a hematology technologist who will reclassify the cells as needed and finalize the differential count. The image analysis software generally is pretty accurate when it comes to identifying normal-looking cells like segmented neutrophils. However, the software is less accurate at identifying distorted, immature, or dysplastic cells. In this case, we can see that a number of cells were classified as unidentified. In addition, a couple of cells have been classified incorrectly, including this basophil that has been classified as a segmented neutrophil, as well as an abnormally segmented neutrophil that has been misclassified as a basophil. The technologist would reclassify these cells prior to finalizing the differential count. In addition, when abnormal white blood cells are present, the technologist will generally perform a manual review of the entire slide under the microscope to further verify the differential count. This is a differential count being performed on images obtained from a patient with neutrophilia. At the top of the screen, we see a predominance of segmented neutrophils, fewer lymphocytes, monocytes, and some immature granulocytes at the bottom of the screen. If we switch to another field of view, we can now assess the red blood cell morphology. By clicking on the screen, we can see larger images of the red cells and assess for signs of hemolysis and other morphologic abnormalities. This is another patient who presented with leukocytosis. In this case, we see a large number of large atypical cells with high nuclear to cytoplasmic ratios. Underneath those cells, we have occasional nucleated red cells as well as disrupted cells, which can affect the accuracy of the differential count. We can click on each of the atypical cells and see that they are large cells with high nuclear to cytoplasmic ratios and open chromatin, consistent with blasts. This slide would then be further reviewed by a pathologist. After the lab completes its testing, a final report is generated for the patient's medical record. This is a sample report for a CBC with differential. So let's briefly walk through the components of this report. Up at the top, we have the CBC itself. So this is what you would get if you just ordered a CBC without differential. The CBC includes the white blood cell count, the red blood cell count, the red blood cell indices, and the platelet count. On the right side of the report, we see the reference ranges for each of these parameters. It's important to note that the reference range will vary slightly between laboratories and will also vary with the patient's age. For example, an MCV of 115 femtoliters may be normal in a neonate, but it would be markedly macrocytic in an adult. The age-appropriate reference ranges will be included on every report. Now, because this clinician ordered a CBC with differential, we have the differential count reported below the CBC. Now, I can tell that this is a manual differential count for a few reasons. First of all, we have bands counted in the differential. The hematology analyzer is not capable of differentiating segmented neutrophils from band neutrophils, so this differential had to have been performed by a laboratory technologist. The other clue is that the differential percentages are all reported in whole numbers. This is because the manual differential only counts 100 cells. Because the analyzer counts a higher number of cells, the automated differential percentages are reported to one decimal place. For example, in this case, the lymphocyte percentage might be 40.2% instead of 40%. On the right side of the report, we again see reference ranges for the differential percentages. Please note that these reference ranges are not clinically useful in isolation and have to be interpreted in the context of the white blood cell count. When we multiply these percentages by the total white blood cell count, we get the absolute differential count. This count tells us the absolute number of each type of white blood cell in the peripheral blood. The absolute differential is clinically useful for determining whether the patient's white blood cell subsets are within the normal range. As an example to further illustrate this point, let's say that we're looking at the differential percentages and we see that a patient has 80% lymphocytes. The actual meaning of this finding is dependent on what the patient's total white blood cell count is. For example, if the white blood cell count is 20,000, the absolute lymphocyte count is 16,000, which is markedly elevated. The patient has lymphocytosis. However, if the white blood cell count is 1,000, the absolute lymphocyte count is only 800, which is not elevated. The relative percentage of lymphocytes in this patient's blood sample only appears increased because the number of other white blood cells, like neutrophils, is markedly decreased. So to briefly summarize what we've learned today, we've gone through the steps that the laboratory takes to complete and report a CBC with differential. We've described the difference between an automated and a manual differential count and discussed the indications for a manual differential, and we've learned how to interpret a CBC report. Before we conclude, I'd also like to remind you that the lab is full of experienced technologists and pathologists who are happy to answer any of your questions. Thank you for completing this module. I hope that you found it informative, and I hope that you'll check out some of our other HemePath modules on pathelective.com.